Today I'm going to be talking to Dr. Pathare. He is a psychiatrist, adult psychiatrist, and he has a fellowship. He's a fellow of consultation and liaison psychiatry, and he did so at Yale University, and is still involved in academic psychiatry and education. But that's the Dr. Pathare's CV is not the reason he's here. If you guys already know our podcast, you know that we care much more about critical thinking, and Dr. Pathare is a guy that can smell nonsense from a mile away, and the fact that he dismisses it with humor is just a cherry on top of the sundae. So, Dr. Pathare, thank you for joining us today.
Thank you for having me.
Dr. Pathare, would you mind telling us from a clinical perspective, in what kind of settings do you work nowadays?
So let me just start with, if you can refer to me as Om, it's better because we have always known each other that way.
Oh, okay, we can do that.
But my setting is kind of complex, and I chose to keep it that way. So I have set up an outpatient consultation / collaborative care clinic here. I spent most of my time there. I also spend a little bit of time on the inpatient consultation service. You'll notice there's a theme coming up, and dabble a little bit in neuromodulation, specifically ECT. The rest of my time I spend involved with residency education.
How does it feel to be a psychiatrist nowadays working in those settings?
It's comforting. You're not too attached to any one avenue. You kind of keep a variety of, I think, not just complexity of cases, but also, I think, degrees of freedom of practice. I think it's not more or less, it's just a different kind everywhere. And that's what keeps me, I think, still interested.
Very good. Keeps you excited about your job. What do you find particularly frustrating on your sort of, do you have any specific things that really get to your nerves with being a psychiatrist nowadays?
Mm-hmm. So I think one of the, if you kind of pay attention to my setting, I think one of the primary things you'll come up against in consultation work is how little understanding of psychiatry actually exists outside of this narrow specialty, sometimes even in our specialty. So let me expand a little bit on that. So for example, we get called for patients who may be terminal and who just learned that they are terminally ill and have a very little bit of time left, and we are called to see them for depression, which may still exist in that setting, but not it, right, like kind of asking us to come in and evaluate them for a mental illness right after you've told them they're going to die might seem a little hasty. On the other hand, we deal with, and I think I'm going with your theme here, the lack of understanding of psychiatry amongst psychiatry practitioners overall, when as a consultant, we are left cleaning up their mess. So for example, the 85-year-old delirious woman who comes in on several hundred milligrams of amitriptyline from back in the day when it was in fashion, plus some zolpidem to help her sleep, plus some benzos to help her anxiety, and modafinil because she's too tired in the morning. That we'll take a look at who's prescribing all of those things, and sometimes it might be someone else, but unfortunately, we do get our fair share of people who practice psychiatry as well. So I think as as uh, uh, as the janitors of the psychiatry world, we are often left up cleaning other people's messes, and it exposes us to varieties of practice which are sometimes unnerving, sometimes demoralizing, but nonetheless actually pretty fun because you're working to correct everyone else's mistakes.
That makes a lot of sense for me. I frequently say that it's a much harder task to be part of the solution than it is to be part of the problem. But nevertheless, personally, I experience a lot of frustration, and I feel at times I feel pretty depressed, state, not rate, as a result of getting new cases that you're inheriting or transfers from other providers, and then when you see what you have to do, and do you face a lot of friction from the patient when you have to make those changes? Because there's, I think, so many things here. Like, for example, and of course, population don't know, and that's one of my claims in favor of and we had this conversation before, not in the show, but we had a nice conversation about guidelines, where I say, well, we may need guidelines, and you say, well, I think they're you spoke about the limitations, which I'm going to just be careful with the words I choose. And then I ended up agreeing with you, and you said, well, maybe if we were using guidelines now, things will be a little bit less messy, not necessarily better, but just less harmful. But then we get patients in there, because what I was saying is that population doesn't know when a doctor is reasonable or not, but if he's likable, that should do the job. And we have, even like Gabbard talks about transference to medications. So I guess that's my introduction just to ask you, do you face a lot of resistance from patients when you're trying to fix their soup?
I didn't know we were going to talk about religion, but
I'm a psychologist, man. I still think that if we still had psychology, psychiatry would be a little bit better too. But we'll get there.
I'm not going to comment on that, because I think focusing on your initial question, I think the resistance. Actually, that's one of the reasons why I really like CL psychiatry, and I went in this particular direction. Yes, there is resistance. Like, I supervise residents all the time, and we see that it is very easy to, like, this is a very common idiom in most languages, but it translates to, like, it's very easy to kind of grant a reward, but it's very easy to revoke, like even a penny. Like, so it's very easy to prescribe, but very hard to deprescribe.
Yes.
And often, I think the role of a rational prescriber is more deprescribing and less prescribing. In this day and age, it should actually be careful prescription, but because of the culture that we practice in, I think we are left holding the burden of deprescription. It is easier to do that in a consultation setting. We can actually focus on what is wrong here in the picture and try to fix it. It's less about relationships in some ways. We have to have a relationship, but the depth of rapport that you might need to do the right thing in a consultation setting is very different from, let's say, an outpatient setting. The liabilities and the players in the game are also very different. So, for example, if I have a 70-year-old lady who's been on Xanax all her life come in, it's going to be a very difficult job for me as an outpatient provider to decrease the dose.
I know.
That requires a contract, and that requires people following through on that contract and all the other things which go with it. On the other hand, if I'm seeing the same patient after she's had a fall in the consultation setting, I can make very concrete recommendations about get this medication off and wash my hands. It might be a more cowardly way of doing business, but at least it's a more satisfying way for me.
Well, let me tell you, I think the task is so, I just want to correct the cowardly word that you used there. The task is so damn difficult that if we can just know who is where doing, like using some sense, like I have a lot of, I do mostly outpatient, and I inherit a lot of cases, or I get transfers of a lot of patients who have been taking benzodiazepines and I have failed tapers. I have failed, and that hurts me tremendously. I went very slowly, but you got to understand, we have to at times understand, and gladly that's the unicorn. It's not the horse, right? That's the rare occasion where I say, okay, we tried, we did everything we could, but your brain has been soaked in this thing for so long that if we persist in this thing, and you know, specifically, like for example, I had a case of a 70-year-old lady on Xanax who and she had a bona fide diagnosis of bipolar disorder with quite wild admissions through her life, and enough witnesses to confirm that. And I failed, and I tried hard, and you know, all kinds of things went south. She goes to the hospital, but then, you know, she was seen by psychiatry in the hospital, but unfortunately the feedback was not the one you would expect, which kind of leads me to my next question. Why do you think we got here? Because you see, if you open any book, right? You open any book, it doesn't matter. You know, you don't have to be too picky about what you're trying to read. You don't have to have a deep knowledge of who's out there and who's receiving grants from pharmaceutical industry. You don't know. But most books have reasonable recommendations when it comes to treatment. How did we get here?
I should have worn a red shirt to suit this answer. But I think it's so. Let me give you a somewhat cross-cultural view here.
Okay.
I'll start with an example. Actually, just like, do we have time if I launch into like these side topics, or
we can talk 3 hours if you want.
So, for example, in oncology in India, people avoid prescribing opioids for anything outside of bone meds. It's not a definite no, but the level of pain that you have to kind of at least have theoretically to get an opioid prescription in India is very, very different from the theoretical level of pain here. They focus on things like, hey, we don't want to get this patient addicted. The patient's going to die in like bloody 6 months. Like, what addiction are we talking about here?
Fair.
On the other hand, they are a lot more free with prescribing antibiotics. For example, if someone shows up to your door and saying, my kid has a cough, like, here, take some antibiotics and get lost. The cultural value of treatments and different kinds of treatments is different, obviously, in countries. For example, a lot of folks that I met in primary care settings during my medical school would gladly take a shot over a pill because a shot is direct and it's supposed to be more effective. They would want medications which have some more perceived adverse effects because that's the way you know it's working, because if you're giving them side effects. If the medication doesn't really give them side effects, they're like, oh, this is like a sugar pill. So I think what we are dealing with here is partly expectations, which come with what level of distress has to be alleviated, the pressure that managed care creates on practitioners in order to keep a stable population base, the ratings and everything else which go into your practice, and the fiscal responsibilities associated with it, and overall the drive on like this dream, right? Like, I can live a perfect or problem-free life. So every problem has to have an answer, and unfortunately, I don't think people are ready to hear, neither the people who are asking for things or the people who are handing them out, that problems may sometimes not have an answer. For us, it is pills. For, let's say, orthopedic surgeons, it might be back surgeries. For someone who's dealing with like a very specific thing like, I don't know, venous sinus pressure in the skull, it might be some kind of a stent, which is as valid and as proven as Buspar or buspirone for, let's keep buspirone for, I don't know, PTSD, but still people use it because there exists this hope that we might fix a problem somewhere.
It's so funny. I mention a lot of that in my mentorship program as well. I say psychiatry is so out of whack right now that and I know you don't, I'm trying not to go to psychology here, but each psychological theory, and probably all of them together, you can extract some absolute values from it. You can say, for example, depending on what theory you're looking at, you can say, okay, this is good. This is always good or nearly always good. And when you look to the SM, the thing that seems to be always good is the effort to prevent any feeling. And we overdiagnose human conditions. And from a practical standpoint, as long as someone goes to the office and says, last week I had 2 days when I was anxious, likelihood is the doctor's going to say, well, let me try to throw something at you to prevent that. And in the same breath, the buzzword mindfulness was thrown on top of psychiatry as a patch over like a Band-Aid over an open wound.
Mm-hmm. I think regardless of who's doing it, I think I have deep reservations about anyone foraying into normal behavior. I think normal behavior has become more and more, it's an embattled position. Let me put it that way. The repertoire of normalcy is vast. However,
Okay.
For various reasons, pathologizing the edges of normal has always been a trend. And it's not just for psychiatry or the medical profession. The territory on the edges is always the one which is more permeable to other influences outside of those concretely marked lines.
Try to explain that a little bit better.
Yeah. So, for example, right, if you look at the diagnosis of autism spectrum disorder,
Okay.
I think an interest, without really putting my nickel down on either side, what you'll find is a lot of the studies which looked at autism spectrum disorder initially, and compared them to the current studies. There's an excellent article published, I think, a couple of years ago, which showed that a lot of the people who had been pegged in the normal categories, to compare them to patients on the autism spectrum, back when autism spectrum was initially being defined and well demarcated, would now actually fall under the autism spectrum.
Yes. And yeah, like the spectrum opens the door to embrace complexity in one sense, but the number of false positives just skyrockets.
And I think we should never have to be in a position where we have to define or work with normal, is what I'm saying. There are several types of norms, statistical, typological, or whatever you're looking at, ideal. I think we have to have a careful understanding of what the norms are that we are dealing with, because otherwise we might be treating a lot of commonly accepted things as delusions. I'm just kind of trying to throw bait out there, but I think what makes one thing acceptable versus another thing not acceptable. And I think if we get into the philosophical ramifications of that, it becomes too heavy for a Monday morning. But
for our podcast as well, probably.
The issue is, though, we are fairly good at knowing what's abnormal, as just by the virtue of being human, more so a specialist, as you kind of hone your implicit processes and also work on making those implicit processes explicit, so that they can be cross-examined and regulated further. I think we can become fairly decent at knowing what's wrong and what needs to be fixed. If you look at kind of straying outside of the field, you'll find more and more messy scenarios pop up. Like, I don't know what this is, but I must fix it. Because unfortunately, we have tools. We might not have an understanding of what the problem is, though. And the tools might not really work for that problem.
So my first reaction was to disagree with you when you said that we're very good at identifying what is normal or abnormal in that sense, or what needs attention. But let me tell you, what I was going to say is that my initial thought was like, wait, because this discussion came to mind where I was discussing with a group of providers, and they were talking about a diagnosis of maybe a 16-year-old girl whose parents told her she could not go out with her friends, and what she did was she jumped out of the window, but it wasn't like a suicide jump, it was a small jump, and she kind of not jumped, but kind of got out of the house through the window and went to meet her friends. So the parents present, among other things, with that, and one of the people involved in the discussion said, "Well, that sounds like a very risky behavior. She probably has bipolar." But my point was to say, wait, that was her perception. But then on a second thought, I think you may be right, because if we take into account that our efforts to classify a problem are too limited and again, I'm always very careful when I talk about DSM, because I don't have an alternative out of my pocket other than just look at the DSM using a brain. But that may have actually blinded this group of providers to actually think that, to think, risky means pathology, as opposed to say risky means life for teenagers, or having fun is risky.
And let's actually, so that's why I deliberately use the word by the virtue of being a human being, and then by being an expert. So I chose that order in deliberate for a deliberate reason, because I think we often. So my entire pet project, this is just a side, my entire pet project is to make descriptive psychopathology more accessible, and in fact a compulsory part of residency education. We all use it, but less than 20% of programs have anything more than 2 hours of teaching for it. We often use these terms of art, and we don't know what they mean. This leads us to using those terms and diagnoses, which are based on those terms, in ways that are not only wrong, but often as a crutch to support instinctual actions. Instinct might not be wrong, but I think it's good to identify what that instinct is. So, for example, right, when someone says this 16-year-old patient's example, jumped out of a window, risky behavior, the instinct is not classifying disease. The instinct is, am I liable for this patient's behavior? Am I going to be sued if I do something wrong? That is a fear-driven. So it's a fear-driven diagnosis. It's not a step which is made out of, like, let's say. Let me give you another example to make this a little clear. So when they show, you're familiar with that study where they showed home videos of people, birthday parties of children, of people who would later
develop schizophrenia? Yes.
People were able to pick out the kids who would develop schizophrenia about 85% of the time.
Yeah.
So that's a substantial number, and they were actually no better than undergrads in psychology or whatever. We shouldn't expect that category to separate out because they're in all essence lay people. But we can pick out as just, if you are within that broad spectrum of normal, you know what's outside of that spectrum. I think what's important for specialists is, and that's why I said, we recognize things implicitly. But if we rely on implicit reasoning alone, what we exclude is cases which are more complicated and which have more than one layer of presentation, along with things which might require an understanding of psychopathology or medical pathology related. It's nothing's non-medical, but medical pathology. It might also be like the place where your biases kind of get reinforced in an echo chamber, right? Like especially for patients with personality disorders, etc. So we need to be able to make those implicit reasoning processes explicit, use the right framework to do it, and have a built-in mechanism to see, okay, if I said this patient is risky, for example, what exactly do I mean by risk? Is it risk from all future harm? Is it risk from medical illnesses? Because, yeah, sure, all teenagers might be risky for some of the other behavior because frontal lobe problems. Does that necessarily mean that it is a disease process? Is that necessarily something that I can alter? So all of these things kind of go down the decision tree later. And if you are kind of just looking at it as a black or white and white thing, like, oh, is this risk versus non-risk? Then you should perhaps not be practicing.
I like what you're saying. I wonder, because one thing that Pedro and I have discussed before on an episodes was because you basically were saying, being under the curve gives you a very good idea of what's not under the curve. But then we have we have personal differences, because some people are quite, let's take, for example, emotional, let's call emotional intensity, let's call emotional reactivity. Okay, let's put in one end of the spectrum people that will meet criteria for schizoid personality disorder, like minimal emotional reactivity. And the other end, we're going to put people with either borderline or histrionic personality disorder, and most of the population is going to be in the middle of that thing, right?
Can we avoid schizoid because some of the A's might actually be a different problem altogether, not really a personality?
Yes, and my whole goal was just to, I know what you're talking about, but my whole goal is just to talk about the amplitude of emotional experiences.
How do we
we just have phenomenology, not descriptive phenomenology, just actual phenomenology, like people's descriptions on how they feel.
Accurately, I do not think we can say with confidence that the emotional repertoire of patients with, let's say, schizoid personality might be limited. Who are they talking to tell you?
Well, fair game. We don't see them too frequently. I see them mostly in my personal life. I never saw a schizoid personality patient, if you will, unless, of course, they have a primary, if you will.
Seen two at one of our training institutions. And what's interesting is the range of emotions. So the rate of change of emotions might be, and the total repertoire of emotions might be different, but the overall range of emotions was certainly not limited.
You had that feeling? I would like to see more of that. That's not my view of it at all.
At least one person went from leave me alone to just absolute rage at the world very fast. And there was no target for the rage. There were no adverse life experiences. It was just ended up on the unit by accident, obviously, because of an incorrect admission. But fortunately, we were able to discharge that individual very fast. I think speculating about a category where we just don't know enough, we can choose a different one, right? Let's say, do you want to choose obsessive?
Why don't we go just from because what I was looking for was individual differences that would impair people's abilities to tell what's out of the not under the curve, if you will, or out of normality, and that's what I was looking for, like the way emotions are experienced. Because my view of it is that we have zero reasons to infer that everybody feels the same, and that is my problem with the statement poor emotional regulation, because it comes with the assumption that everybody feels the same and this group of people can keep it together, as opposed to say the experience is really different from the bottom up. But we can go with cultural differences. And one of the things that came up when I was talking about a similar topic was that if you tell in Brazil that a teenager escaped her parents through the window to have a nice night of fun with friends, everybody was just chuckle, right? But maybe, and I wonder if in America that has a different meaning, because in so many senses.
On the other hand, if you say a teenager disobeyed his parents in let's say rural India, that would be okay, we have a serious problem here.
Exactly. So that's what I'm trying to say, is that is how, because I like what you're saying, man, and I'm really looking into, because my next question is going to be associated with that, and that's one of the things I would like to ask you, and that's one thing that I've been asking a lot of people. It's how to fix where we got. Is this a bottom up, or can we really trickle from the top down? The changes, and let people do their boards and answer their questions with this sort of a brainless approach, and after that start actually thinking. But my question would be, if you can advocate a little bit more over this perception that we are good at telling what's normal and what's not, because I haven't had that impression. But again, maybe people are making those claims based on how square and rigid DSM has been understood, not necessarily how it was meant to be.
I think, yeah, let's unpack that in a moment. But I think one of the things I just want to put a plug in for before we move from the previous point was, like, the issue is not whether you're having fun in Brazil versus having fun in India versus having fun in America. The issue might actually be, what is your understanding and your actions based on the consequences of what will happen if you have fun in any of these countries? I think that might be the point to look at, rather than just a teenager, right? Like, so for example, if you travel to an extremely conservative country, and that if you have any kind of extra fun, you might lose your life or limb. The risk with that kind of fun is very different than, let's say, going to a party in Rio. Because you are engaging in the same activity. You might be the same age, but on one hand, you're a 16-year-old who understands you might be stoned versus a 16-year-old who might be stoned.
Very good. That makes absolute sense. That makes absolute sense, because which brings us, which has I see it, and of course, since the 50s, and after that, since the 50s with behaviorism, and after that with which, if you like behavioral sciences, but behaviorism is still a philosophy, and after that with evolutionary psych. Yes, and after that, evolutionary psychology, which still is. But listen, adaptation, knowing where you are and what you have to do is an absolute value.
All of that is like it is. Some of them make good arguments, no doubt about that. But so much of it is post hoc. It just annoys me. Like, you're just it's non-falsifiable because you're creating explanations after you've observed something.
Yes, it is. It is post hoc because allegedly evolution has already happened to get us where we are. Everything that they will do. But when you see some of those principles being applied to marketing or and you see, and the matter of fact, I'm going to say something that I know is really not your passion here, but it has, psychologists have, and I'm really talking about Freud and Jung as well. They have been talking evolutionary psychology for more than 100 years. They just used a very funny way of talking about it. Yeah, you are right. It is post hoc, but I think, there's many arguments in favor. And again, we don't have to go there because now we're talking about where we reach our limits, and we may not be there. We could be doing a better job with all those things. We have worked on an episode. It's not aired yet. I think it may be by the time we talk. I'm not sure, but where we really, where we're saying that bringing medical philosophy back would cut, and then, but going a little bit further, like, did we the dip psychiatry faced after DSM, from DSM-3 on, could it be related to the fact of excluding psychology? Granted that the way psychology was entered in DSM was quite wild, but it seems that there's an effort to make a purely medical art, if you will, devoid of whatever psychology has been saying for a long while. But some of the conclusions, like even, even I think I'm derailing here. I want to go back. I just want to go back and finish this thing with a question for you.
Yeah. So your question was about like how where we are, right? And how did we reach this point and what we can do.
Yeah, that's how the whole thing started. Yeah. And then I think the next question will be like, how can we fix? I think you brought up something very interesting. You said descriptive psychopathology and your descriptive phenomenology, which is, I can't agree more with you. If you remember, you are the guy who sent me a link to a book that I still recommend to everyone, Descriptive Psychopathology.
Or the Alan Taylor one. Alan Taylor, I think. Michael Alan Taylor's book. Yeah.
I think so, yeah. And of course, I was a psychologist before. I was exposed to that kind of thing, but from a more phenomenological perspective, not so much objective observing, except for the behaviorist side of things. So in addition to that, do you have any thoughts of what could we be doing other than, of course, waving a flag as we are doing right now? What can we do so we make a dent on this process?
Yeah, and several thoughts. I hope you have your pen and paper ready. But I think it can be boiled down to do your job, and I'll unpack that. I'll unpack.
Please.
I think there are several. I think there are several domains, but I think three of them are the most important, right? Like, for example, one is knowledge. The other one is having a coherent philosophy driving your practice, and third is having an understanding of your responsibilities and limits. There are several other sub aspects of it and other things that we'll perhaps ignore for the interest of time and clarity. But I think on the knowledge aspect, for example, one of the things that we should kind of, I think, resign ourselves to is that we have the materials that we need to practice in a reasonable fashion at this point of time. We are not going to treat everyone. We are not going to be successful in doing so. We might, some of us might be practicing at the cutting edge, but most of us aren't going to be, because that's how a normal distribution works.
Fair.
It's nothing against the individual. It's nature. The DSM, for all its problems, was intended to increase iterative reliability and create a common language. I think we do not have a better alternative. And going to your previous comment, I think even if we were to integrate some advances in psychology to it, I fail to see right now how they could be integrated in a seamless fashion, and also how they could actually be paired with treatment. But that's perhaps a lack of understanding on my part. I think as far as your thoughts about treatment guidelines, we have reasonable treatment guidelines. They might be needed to interpreted and implemented correctly with that understanding of not just their letter, but the spirit of the guidelines. And that's what they are, right? Like, they are not mandatory. They are not mandatory, and they are not an absolute must. And they are called guidelines precisely for that reason, because there is room for interpretation. But I think that interpretation must be guided by either an understanding of the rest of the evidence, which is outside of the guidelines, or a good understanding of the patient who is in front of you, who might sometimes necessitate straying from the guidelines. If not, and once again, spirit more than the letter. But I think the slippery slope we end up with is if we start focusing on the spirit before the letter, we end up straying from the spirit as well. So I think there has to be a progression in which we implement some of our practices.
It's tempting to think that every patient is an individual, but these individuals actually make up the statistics. So if we start treating everything as an exception, nothing is. So I think once again, preponderance of data is what should guide our practices. And if we come up against an exception, then treat it as such.
Thank you. Thank you very much. That's I was trying to convey that. Very good. Thank you very much.
The diagnostic clarity is a problem, though. So I think what we struggle with is shoddy diagnoses and subsequent non-falsifiability of these diagnoses, because I can't disprove you didn't have mania, even though what you said sounds nothing like mania whatsoever, and you were doing too much cocaine.
Right.
But because it's in there, and because of the atmosphere and the culture we practice in, which is sometimes, like, for example, bipolar disorder might be associated with creativity, genius, etc., and might be more acceptable socially than some other pathology. There's attachment which comes to that diagnosis. So I might find myself struggling against not only the risk of liability of you turning manic, but also your insistence that I am bipolar and do not have another pathology which is actually clear in front of me right then and there. So be very prudent and cautious in diagnoses. People are both, and we live in a strange time where people are both under and over diagnosed with the same condition, and as well as under and over treated with medications for those conditions. It's actually a fancy way of saying we are wrong a lot, or at least wrong more times than we should be. So I think that's why I was kind of making that initial plug for restoring normalcy, and not really messing around too much with it, because I think we shouldn't be using a terminology as, like, a lot of pop culture is has kind of percolated back into psychiatry and psychology, and there's a lot of shoddy diagnoses being made based on perceptions of what we might ourselves have, or what the patients think they might have. And I think what we struggle with is using terminology as a crutch rather than as a tool in making appropriate diagnosis and formulating treatment options.
Makes sense for me. Yeah. One of the thoughts I have in regarding to, it's where the focus of research and all the grants are right now are really into drugs. And when you take a book like Symptom-Based Rates, the newest stuff from symptoms is probably the year 2000, 2005, the latest, because there's no more research on phenomenology or descriptive phenomenology. And we're still trying. It's like we stopped a little bit too short of actually describing our diagnostic entities and went to, okay, now all the money goes for the drugs and the biological markers, which we're not going to find because they're markers of what?
And we are talking as if we understand what these terms mean, right? Like, for example, you can pick your choice of whoever is conducting the study somewhere. And excuse me, this keeps locking me out. Sorry. So you can take your pick. But I think if you pick any term from a scale which has a lot of momentary ecological validity, and look at things like recency bias and all of the other crap which comes with these instruments, or even an understanding of what the terminology used in those scales means, we might struggle with the issue that some of these castles may have been built in the air. Like, you take an average resident or a trainee or whoever that you're working with, and just ask them, what does lability actually mean?
Okay.
What does it mean to be? We use that word a lot, like labile this, labile that. What does it mean? Is it how much change? Is it how fast of a change? Is it a combination of both? We use terms like flat affect, what does flat mean?
Fair.
What are we expecting here? Is it flat if the patient has Botox? Is it flat if the and if you look at the requirements that dictate our examinations, you'll notice that things are getting shorter and shorter, and more streamlined does not necessarily equate with good. We are looking a lot of people who are being taught, and that's my personal battle. A lot of things that people are being taught as if the DSM is a textbook, which is not, and as if the insurance requirements are the totality of what you need to think or write about a patient, and neither of those is true. So I think we have some categories where we have an understanding of what the disease process looks like. We might not have a clear understanding of the etiology, obviously, but if we treat it as these are the few check boxes and these are the other few check boxes, and I now know what's going on with the patient and what to do with the patient, we are going to struggle with mediocrity a lot. And psychiatry is a field where I think, like, for example, minor procedures in surgery are the exact opposite of psychiatry. You can have a lot of practice with a poor sample, and you can be better at your job, versus in psychiatry, where a lot of practice with a poor sample is actually not going to make you better at your job.
Very fair, very fair. And it's so, and that's one of the concerns I have because of, and probably you do have as well, except that I work in my training institute with folks that I've been working for a while, and I have to sort of go back to, there's conceptions and there's a lot of resistance into learning new things because, of course, gladly, of course, there's a selection bias for people that go and look for my institute, that they're already looking for more, and they're most likely more open to change, old perceptions and opinions, and, have that kind of insight that you have when you read a good book that is, wow, how could I have worked all this time without knowing that? And a lot of people are not open to that because, of course, stepping out of your comfort zone is quite anxiety provoking, and so we have to face that as well, and that at times I ask myself if building bottom up doesn't rebuilding psychiatry bottom up seems to be like a good task for Elon Musk once he reaches Mars. But here we may have to start sprinkling things from the top. So, but Dr. Pathare, do you have any final thoughts on this?
Yeah, just one thing I think that I forgot to mention earlier, which is the last part of my answer to your previous question, which is an understanding of what your responsibility is. I don't know if you remember this from your training days, but we were given that paper, Shooting an Elephant, by Dr. Ram. And I would highly recommend reading it.
What is the name again? Repeat, because my memory is failing me. Shooting an Elephant?
It's by George Orwell. It's a small essay. And I would highly recommend it to all the trainees or whoever else is kind of interested in thinking about medicine. The reason being, I think, we have to understand why we are doing the things we are doing and the pressures that might compel us to do it. If we do not have that understanding, I think all of the knowledge and all of the careful practice might be in vain. Because you might be familiar with all the guidelines and all the diagnostic criteria and do the exact thing that the guidelines are telling you. But why are you doing that, right? Like, so you have a patient in front of you. What is compelling you to take the next step? And I think that essay kind of highlights the pressures that, and it's not about medicine at all, but it highlights the pressures that people who make a decision often face in a very, very rich way.
Oh, absolutely. It's unlikely that I didn't read something that Dr. Rapp, I quote Dr. Rapp with a little bit, with a frequency that's probably a little bit too high, because it usually requires an introduction to talk to him. And I was, even when I was interviewing for a job, and it was funny. I said, well, there was this guy, and he used to say this, and the guy on the other side, he's like a national, he was a CMO for the whole national. She was the medical director for the whole national network. It was another gig. I didn't go there. And he said, "Are you talking about Mark Rapp?" And I said, "Yeah." And he said, "Well, he apparently he went to the same residency program, but Dr. Rapp left earlier than he entered." And he said, "And I was still hearing about this guy." And I said, "Yeah." Dude, I was driving with my girlfriend and interviewing for a job at the same time, going for a vacation. So for me, it's hard to recall that detail at this point. Sorry for that. Listen, again, I want to say thank you very much. I cannot, even though people, I got to say this podcast is getting very good feedback. And whatever we're doing very humbly. Because it usually involves exploring ideas, and I run these ideas by as much people as I can before I open my mouth, and of course we always find some points of agreement and some points of non-agreement. But overall, it seems that this kind of discussion really happens, and I think what motivates me and what motivates the listeners is that. At least we're not alone in the sense that something's off, and we could be doing as a group, as professionals. I feel overall psychiatry is failing American population big time, and we could be doing a better job. And I think this shared sense usually points towards very common points, like very very clear issues, like pharmaceutical industry lobby, issues with diagnosing or turning something as complex as human behavior in a sort of a technical checklist approach to diagnosis and how to fix these things. And that makes me very confident, that my hopes of being a spokesperson for people like you, it's very gratifying, and it's probably the most gratifying part of my career at this point. So I want to thank you for your time and your availability. Tell you, dude, it means the world that you agreed speaking in this podcast. And anytime you have a thought and you say, you know what, I think people could hear this thing. Our numbers are actually going up quite well, and it's I suspect we're going to have a good channel to spread these ideas.
I have several rants. If you, some of them might get you flagged, but it's up to your discretion. I apologize for being a little scattered, perhaps, but I think I was trying to just go with the flow of the conversation.
Yes, and this is it. This is not a lecture. This is not a class. This is a podcast, and the whole goal here is to raise questions. And what it seems that is happening is that, obviously, because of I wonder if political developments over the past decades, knowledge is no longer confined to the universities. And a lot of people are looking for knowledge in different, and I can see that smile on your face now. And a lot of people are looking for knowledge everywhere. And what we're talking about are people that are awfully busy, driving to work, trying to learn at the same time. And people ask me, what should I read? And I try to have recommendations that are easy to be read and useful, that will make a big impact in their professional lives. But if we can, make the listeners' lives easier by learning and, sort of a triggering thoughts that they will have as they're looking to patients, we can actually multiply this thing and have, because my first goal is, of course, that less people get hurt by what we do for a living and more people get helped. But my first goal is let's hurt less, because there's only so much we can do for folks. So let's just start causing less damage, less hyperlipidemia, less strokes, less diabetes, and go from there.
That's our motto as CL psychiatrists, smoothly.
There you have.
I only smiled previously because I think information and misinformation are easier to access. not knowledge. But
Fair.
that's why it's
Fair, yeah, and we could talk about that more in another occasion, because there's something happening when it comes to and I feel it's knowledge, but then again, we could go down a rabbit hole right now, and I think I just want to say, dude, I'm immensely grateful, and thank you for participating today.
Thank you for having me, and as always, like even off the podcast, if you have any thoughts and want to chat about something, I enjoy our discussion, so feel free to text or whatever.
It means a lot. Thank you very much.
All right, take care.